Welcome to this week's Healthcare Careers in Focus. Today we have Zoe with us, a speech and language therapist.
Perfect. Thanks, Jordan. As Jordan said, my name's Zoe, and I'm a speech and language therapist. So I'm going to talk to you a little bit today about my career, kind of what I've done to get to the point of where I am now, and just to give you a bit of an idea about what happens in the day of a life of me. So as a speech and language therapist, I work with patients who have communication difficulties and also swallowing difficulties. And you can see from the current slide, I've just put in a picture that I thought I'd share with you all. So this was from an allied healthcare professional day where we were trying to advertise speech and language therapy as a kind of career and get people to know a little bit more about what we do. And I am making mocktails on the ward for some patients with swallowing difficulties. So this was really good because we got patients who were on modified diets and fluids due to swallowing difficulties involved in making kind of these different mocktails which had different names, just to help kind of raise awareness about speech and language therapy and to get patients involved with kind of making drinks for themselves. So I currently work in Bedfordshire, but I've worked across a few different places, which I'm going to go into more on the next slide. So I qualified from university in 2020. I did a speech and language therapy degree, which was 3 years long. There's kind of different ways you can do it. Some courses are 4 years and you get a master's from it. And sometimes people do the undergrad, which is 3 years. And more recently, I know there's started to be the introduction of apprenticeships as well to do with speech and language therapy. So my first job when I qualified, I pretty much went straight into work, and that was in Buckinghamshire. For my first job, I worked within paediatric speech and language therapy. And as you can see from the years, this was during COVID time. So a lot of this was done remotely, which came with its challenges. My caseload consisted of children basically from school age, from primary school age to secondary school age, and they had a range of different diagnoses, which meant that they had communication difficulties, and all of my caseload had something called an education and healthcare plan, which meant that we were kind of commissioned to give set input based on what was on that kind of plan, essentially. So I worked within paediatrics for a year, and then after that I moved to a stroke and neuro rehabilitation. So I worked 3 days a week on the stroke ward, and here is where I completed my swallowing or dysphagia competencies. So when you qualify from university, you're able to work with patients with communication difficulties, but due to the complexity of swallowing, you have to kind of do additional competencies once you begin working. So I completed that within this time. And for the other 2 days of the week, I worked in neurorehabilitation. So again, this was with patients with swallowing difficulties and communication difficulties, and working with a range of different neurodiagnoses. People might often come from the stroke ward to the neuro rehab ward, which was quite nice to have that kind of crossover of the two, but also we'd have patients that come from kind of out of area hospitals, or they might have other neurodiagnoses as well. And then in 2023 to 2024, I changed hospitals. So all of these workplaces were all within the same trust, but I kind of just bounced around from different sites. And I worked within the general medicine team. So this worked with kind of basically the general wards that you might have in a hospital. So respiratory wards, gastro wards, A&E, frailty wards, surgical, basically any wards in the hospital. And I worked there for a year, and then I moved to Bedfordshire Trust, which is where I am currently. And I'm currently in a split post, so I work 3 days a week within the community. This is general community, can basically cover any diagnoses, anything that may result in someone having a communication or swallowing difficulty. And then the other 2 days of the week I do general medicine, so again covering the wards in a general hospital for a couple of days a week. And this is where I still am currently. So I've tried to include a little bit about the day in the life of me as a speech and language therapist. And I think every day is really different, which is one of the things that I love about the job. So I've kind of just given you a little bit of a taster about what you might expect with my day. So on my community days, I start at 8 o'clock, and first of all, I'd be checking the shared email address to see whether we've had any new referrals come in. So we have different people that might refer to us in the community. So that might include like the GP. We have also trained other people, like other multidisciplinary team members, to refer into our service after we've given them training. So you might get it from like a pharmacist or for a physiotherapist, and they'll always detail, or they should always detail, what the reason for referral is, so that then we can triage the referrals appropriately. So we can then work out what patients we need to see more urgently. So for example, giving them a 1 week estimated or target plan to see them, and what patients can wait longer. So they might have a target date of up to kind of 8 weeks. So an example of somebody we might prioritize is somebody who has had a choking incident which has resulted in hospital attendance, for example. And somebody who might have a longer kind of wait list of up to 8 weeks might be somebody with chronic communication difficulties, who might have had some speech and language therapy in the past, has had these difficulties long standing, but would just like a little bit more support of it from us. Next, I would start to see my patients. So often I like to start quite early. So I might start this at about 9 o'clock. And in the community, our patients can be outpatients. So patients that come into hospital, into one of our clinic rooms to see us. So these might be patients that are mobile and, are able to access coming into hospital for appointments. We also see patients in their home for those patients that aren't able to come into hospital, as well as care homes as well. So an example of the patient, for example, I've seen at 9 a.m. is a patient with dysfluency, or you might know it as stammering. So I currently take on the dysfluency caseload, kind of assessing and giving advice and therapy to patients who might be struggling due to a stammer. Some of these patients might have had a developmental stammer from when they were younger, and now they're an adult. They want some more support with it. Quite often they're having difficulty kind of applying for jobs and things like that. Or it might be a patient with an acquired stammer, so they might have developed a stammer later on in their life, maybe as a result of something neurological. So you can get kind of a stammer post-stroke, for example. Next in my day, I might be going on a home visit. So I might be doing some communication therapy, for example, for somebody who's had a stroke. So there's lots of different communication therapies that you can do with patients. And it kind of depends on what the goal is. So it's all around setting goals with the patient and their family members, and trying to work out what you're going to work on in therapy and what's appropriate. Some communication difficulties someone might have post-stroke might be something called aphasia, where they have difficulty with their understanding and their expressive language. They might have something called apraxia, where they might have difficulties with their coordination of their speech sounds. Or they might have something called dysarthria, which is the kind of way their speech is produced, the way it sounds, how clear it is. Yep. So then next, move on to another home visit. So for example, seeing a patient who has Parkinson's and reviewing their swallowing. So things I might suggest is I might go and see them have their breakfast or their lunch, or mid-morning in this case. And I might see them with a range of different food textures and give advice about what kind of texture food I think would be most appropriate for them to have. We're always thinking about what we can do to make the patient as safe as possible. So we're often thinking about what ways we can reduce the risk of food and drink going down the wrong way. If food and drink goes down the wrong way, this can cause chest infections, which can make our patients really poorly, and patients can also have choking episodes. So with our swallowing reviews, we're kind of giving advice and strategies to help reduce those risks. Next, I might go to a care home to visit a patient with motor neuron disease. So often with patients with motor neuron disease, we can have quite a lot of input around kind of communication and swallowing due to the kind of deteriorating nature of motor neuron disease. It might include things like voice banking, so banking somebody's voice so that they can use that voice later down the line when their speech might not be very as clear. And yeah, again, swallowing inputs are kind of monitoring how they're getting on with their swallowing, whether any modifications need to be made to keep them safe, or as safe as possible. Then in the afternoon, I would do my notes from the morning, write reports. So after we see every person, if we've made any changes in terms of what we're recommending for them to have, or if we need to write up like an assessment we've done, then we'll always send a report to the patient and the GP. And then I also be involved in kind of multidisciplinary team meetings. So for example, palliative care, MDT. So this is where you kind of have a representative from lots of different professionals who come together. We talk about patients that are on our list, so maybe different problems that have cropped up that week, and kind of using different MDT members' expertise in order to ensure that patient's given the kind of best possible care by us all working together to kind of problem solve. So it might include kind of doing, acknowledging that it would be good to do a joint visit together, or problem solving difficulties, for example, trying to do a referral for somebody to trying to do a referral to a professional to help with kind of training a family member on the use of equipment, for example. And then towards the end of the day, I'd be booking in patients for, I've put next day there, but maybe next week. It depends how organised I am. But yeah, booking patients in for the following kind of week or so. And yeah, finishing off all the admin. Might also include kind of doing referrals to other services, might need to give like the GP a call to discuss a patient you've seen that day. Obviously out in community, you don't have the benefit of having like an acute team around you all the time. So there's a lot of kind of admin side of things where you're doing a lot of, you'll have a lot of conversations with kind of different healthcare professionals after you've seen a patient. And then acute, so a little bit different than my community days, but it's a lot less planned and a lot more unpredictable. So the acute setting can go from being really, really busy some days to just relatively busy some days, always fairly busy, but you often don't know kind of how busy it's going to be until you get in that morning. So on an acute day, we come in and as a team we look at the new referrals that have come through our system since the day before. So the wards will often send the referrals, like the doctors, giving a reason as to why they want us to see a patient. And then similarly to community, we then triage those referrals. So we look at what patients are a priority and need to be seen that day, and then what patients are able to wait if we don't have capacity to see them that day. Factors we might be thinking about, for, particularly for our swallow patients, as in the acute on the general medicine wards, it's mainly quite swallow heavy patients that we see rather than communication. We're always thinking about whether that patient has a route of nutrition. So sometimes if a patient is really unwell, the medical team are concerned that food and drink's going down the wrong way and they've got a bad chest infection. The medical team might place them nil by mouth, so they're not allowed to have any food or drink orally due to that risk of the food and drink going down the wrong way. So then when we're prioritising the referrals, we'll be thinking about, if that patient is nil by mouth, have they got a route of nutrition? Like, have they got a tube in their nose, so an NG tube to help with nutrition and hydration? And if they haven't, then obviously they're going to be a priority for us, because that patient has got no means to have any nutrition and hydration until we come and give a speech therapy assessment. So in the acute setting, we see a range of different conditions. So I've just kind of given an example of a couple that we might see. So, for example, someone might come in with MS, multiple sclerosis. You might have someone who comes in with something that you wouldn't think like directly relates to swallowing, but it might be that they come in and they're poorly and it's knocked off their swallowing, which they were kind of, getting along okay with in the community, but now they're unwell. It's kind of tipped them off that baseline. So, for example, someone come in with a history of alcohol excess, they might have come in with a seizure, which has impacted, factors such as alertness, which has then impacted their swallowing. Things like head injury, so that might be that someone's fallen over, they've hit their head, and now they're needing support with their communication, because they might have communication difficulties following that, as well as with their swallowing as well. We sometimes support with capacity assessments in the acute setting. So often if patient has communication difficulties, and for example they might be trying to self-discharge, we might support the medical team to complete a capacity assessment to see whether that patient can fully weigh up the risks of discharging themselves from hospital. Obviously everybody is you if you've got capacity, it's in your right to make an unwise decision, even if it's against kind of healthcare professionals advice. However, if a patient doesn't have capacity, so for example they're confused, they're not understanding the information, then we have to kind of make that decision within their best interest, because they lack capacity to make that decision themselves. We're also involved on intensive care, so we might work with patients, for example, who have a tracheostomy, so they might have a breathing tube. We see a lot of patients that have dementia. And then at lunchtime, we always triage again, because during the day, more referrals might have come in. So even though we've made a bit of a plan in the morning about who we're going to see and who we're going to prioritise, as those new referrals come in, we might need to amend our priority list depending on the priority of the new referrals. And I've spoken a lot about kind of clinical like my day clinically, but there's also kind of non-clinical roles as well. So for example continued professional development or training, so it might be delivering this. So sometimes we deliver training to, for example, healthcare professionals on the wards about how they can support patients with swallowing difficulties, or it might be attending training for ourselves. So for example, attending a training about pain management or other kind of aspects that will help us in order to fulfill our job on the wards. Also have a job role as supporting kind of more junior staff, so that might be more junior staff who are trying to achieve competencies, for example their swallowing competencies, which I might support them with, and also kind of they might come and shadow, for example, or we might have students who are coming to shadow or to work alongside us as well, so supporting other people as well. So rewards and challenges, and obviously this is personal to me, but I just wanted to give you guys a bit of an idea about what I feel are the good aspects and the challenges of my job. So one of the big rewards is the impact that you can have on patients' quality of life, just like lots of aspects of kind of healthcare and people that work within healthcare, but also making a difference to kind of patient experience. So it's really nice when you get good feedback that you've really helped somebody, whether that be within the acute setting or the community setting, and also kind of helping and support network for family members as well. Some of the things that we talk about and discuss can be like quite challenging, and having being able to support a family member through that, and a patient through that, can be very rewarding. I really like working as part of a team. So even in the community where it's kind of, less teamwork than the acute setting, like I said, still do lots of communication with different healthcare professionals, which is really nice to work together, to feel like you're achieving, you're being able to achieve, kind of give good quality care for patients. And in the acute setting, there's lots of MDT working, so lots of liaison with all different healthcare professionals like physios, occupational therapists, GP, pharmacy, which I really enjoy. I really like that kind of interaction as a team and working as a team. I really like that you can work as a speech and language therapist in a variety of settings. So as you know from my introduction, I've worked in a few different settings already, and I haven't even mentioned all of the different areas you can work in. So I feel like that for me is a big reward of the job, in terms of being able to get experience in lots of different places and always feeling like there's new things to learn. Even some of my colleagues who have worked as speech therapists for, a long time, they're learning things every day as kind of new research, new evidence base comes out, and as practice changes as well. So I really like that aspect of the job, that it never feels boring. And skill development, I guess, with working within different places and different teams and different specialities, that helps to develop your skills as an overall kind of therapist, as well as kind of like leadership skills. So once you've been a speech therapist for a little for a certain amount of time, you then might support kind of students, or like I said, more junior members of the team, and take more kind of a leadership role. So it's nice to have that kind of clinical development as well as kind of leadership development as well. Barriers to speech and language therapy, or and some of these apply to healthcare in general. So is the caseload and kind of staff pressures. So often we'll have a lot, when I was talking about kind of triaging referrals and giving an estimated time of when we're hoping to get to those patients, often we're not able to, or sometimes we're not able to meet that target due to the amount of referrals we've received that day, or maybe because we've got a staff member on annual leave or off sick, and that can be quite difficult sometimes, because you can see all of these patients that you want to see, and you want to be able to give kind of care to, but you're not able to give it in the kind of timely manner that you might hope. So that can be difficult, and also stressful at times. Like I said as well, about kind of the emotional side of the job. So obviously we're talking to a lot of patients and family members who are going through very difficult times, going through challenging new diagnoses, and that can be quite difficult and emotional sometimes, which I think is on the other side is one of the big benefits of being part of a big team, because your colleagues are able to relate to some of the things that you might be feeling or you might be going through, and you kind of have that support as part of the team as well. And just barriers to patient care. So often there's lots of barriers in terms of funding, resources available, and that again, similar to kind of the caseload and staff pressures, that can be one of the challenging aspects of the job. So advice to my younger self. So my advice would be to take any opportunity, make a note of it, and make the most of it. So I definitely wish that when I was younger that I had kind of any opportunity I had taken, made a note of it, because often when you're trying to draw on experience later on, when you're trying to give kind of evidence, might be in an interview, or maybe when you're revisiting an aspect of something that you got some experience in way back when, you often can vaguely recall what you did, but you've kind of got no documentation of it to kind of back it up or to remind yourself. So definitely taking a note of any experience that you do get, even if you think, oh, that might not be that beneficial, I might not do anything like that in the future, still make a note of it, because you never know where your career might direct you. And when I say take any opportunity, I mean any kind of work shadowing you can get, any opportunity to kind of shadow any professional, even if you think you're not directly interested in that specific speciality. I definitely recommend this, because I know from experience that I've done some work shadowing of different healthcare professions that wasn't speech and language therapy, and that actually then led me to pursuing a career in speech therapy. So I think you never know, you might go and shadow elsewhere, and it then leads down a different route, and any experience, even getting, say for example in my case, wanting to pursue a career in speech and language therapy, even experience that I got shadowing, for example, occupational therapy, was really useful for me to be able to gain a bit more of a holistic view of the job, and also to use when kind of documenting my experience, for example, for interviews and things. And on that note as well, like applying for interviews, once you're kind of directed more about what you kind of want to do, even if an interview doesn't seem completely up your street, still applying for it and giving it a go, because again, you don't know, you might get there in person and they might tell you more about the job that you find more interesting. So yeah, and it's really good experience just to get interview experience anyway, just to go through that process of having interviews, which can be really useful. So yeah, that would be my advice. So I'm just going to talk through a case study of somebody that I've worked with recently, just to give you a bit of an idea about someone more particular. So talking about patient A, so they have a diagnosis of a left temporal and left frontal infarct. So they've had a stroke. This stroke affected their communication. So in the temporal region is often where your language centre for understanding is, and the frontal region can be where your expressive language is located. So yeah, kind of the left side of the brain is often where communication can be impacted if you have a stroke on that side, if you're right-handed. If you're left-handed, then sometimes it can be a bit more complex. But anyway, for this patient, their communication was affected post-stroke. So I started working with them 5 months ago. They're 30, so they're very young. They were working prior to their stroke. They had lots of hobbies, they had young children, so a lot of their life was kind of activities around the children, but they also had hobbies, for example, like meeting up with friends, going to the cinema, going running, so quite active, and lots going on for this patient, which obviously means that when we're thinking this patient's now had a stroke, there's quite a high baseline for this patient to get back to, because they were doing all of these things pre-stroke. So they were in hospital, they were on the stroke ward, so seen by the stroke speech therapy team. They then moved to a rehab setting where they had ongoing rehab, not just for communication, but for other aspects like mobility, for cognition. And then, or now, they're currently in a care home. Not sure if the care home setting is going to be for the foreseeable. They're kind of awaiting further assessments to see whether they can return back to their own home. So that is where they are currently. So yeah, like I said, they've got communication difficulties, and I explained these a little bit at the start of the presentation, but aphasia, so difficulty with their expressive and receptive language, so their understanding and their expressive language, so like they had word finding difficulties. Apraxia, so difficulty with the coordination of their speech, and dysphagia, which is swallowing difficulties. So what my treatment and support entailed. So I was involved with the swallowing side of things. So like previously mentioned, I was involved with kind of assessing their swallowing to see whether we could increase their diet texture, for example, or whether we could reduce the thickener that they have in their drinks. So thickener is sometimes used to help with the flow of fluids to make it safer for somebody to swallow. So this patient was put on thickened fluids when they had their stroke, and then when they moved into the community, I was then involved in the kind of assessment process in order to help them to return back to having normal fluids. And with regards to the diet, when they first had their stroke, they were on very modified diet. So they were on something called a puree diet, which was very blended food. And now currently they're on a much less modified texture. So they've returned to something called soft and bite-sized diet, which is basically food that is very soft in bite-sized, very small pieces. So I was involved in the process of that. This also include a videophroscopy. So speech and language therapists can carry out an X-ray of somebody's swallowing. So we do this at the hospital. Patients come in, they can have a videophroscopy as whilst they're an inpatient, or they can come in as an outpatient, and we run these clinics. So for this patient, I was involved in running the clinic, doing an assessment of their swallowing. Videophroscopy can be really useful to see what is going on in terms of the swallowing when it's unclear about what's going on at bedside. So for example, at bedside, we might see that this person isn't showing us any signs that food and drinks is going down the wrong way. However, they're getting recurrent chest infections, and they've got something in their past medical history, for example, like this lady who's had a stroke. So therefore we can do a video of their swallow to see exactly what's happening in order to kind of support our recommendations. And this might also include using strategies to help with swallowing as well. So with this lady, I was also involved in augmentative and alternative communication. So this is using different communication rather than just their speech in order to support communication. So for example, she used a lot of writing. So we worked on writing. She also used an app called Predictable, which allowed her to kind of a bit like predicted text. It allowed you to start writing a word, and then the app can try and guess what you might be trying to say when you write the first kind of couple of letters. So this was useful because when she was having difficulty with expressing, certain language and certain commands, she was able to use the app in order to communicate with kind of the multidisciplinary team, her family, her friends, care home staff. We did some communication therapy. So we looked at things such as semantic links. So this looks at kind of the semantic links between different items. So for example, you might have a picture of trying to think of an example. You might have a picture of a book, a newspaper, a book in the middle, and then the options of like a newspaper and water, and you have to say which does the newspaper or water more go with the book, like which one is kind of more semantically similar. So obviously in that case the book and the newspaper would go together because that's both items that you read, whereas the water is something that is not semantically similar. So it's working at that kind of basic level of understanding of kind of semantics around things. We also used a melodic intonation therapy. So this is where you kind of use rhythm and I guess singing in some ways in order to produce expressive language. This can really help with patients, for example, patients who had a stroke like this lady, because singing taps into a different area of the brain. So that can often help with kind of expressive language. Like I said, we did a lot of work on kind of writing. So this used things and writing and typing. So this used things such as anagrams. So for example, presenting the patient with a picture of something and then giving her the anagram tiles to rearrange to create the word. Apraxia work was working on the coordination of her speech. So this is often a lot of kind of drilling of for example, specific sound work. So for example, if they were struggling with a particular sound, such as B, it might be drilling using kind of modeling, mirrors in order to support that patient to physically make that sound with their mouth. I spoke a little bit about apps and functional goals as well. So like for this lady, like I said, she had quite a high baseline. She had young family. So a lot of her goals were things around kind of related to her family. Like she wanted to be able to participate in kind of reading her children bedtime stories, for example. So it kind of draws back, obviously, we do all of these things in the background, lots of different therapy approaches, but it all should come with the kind of relate to the patient's specific goals. And for this lady, for example, her family were kind of quite key in that. So multidisciplinary working with this patient, there was a lot of multidisciplinary team working. So for example, with the dietitian, so ensuring that the dietitian had the kind of oversight and management plan, ensuring the patient had enough was meeting their nutrition and hydration needs, alongside us kind of suggesting modified diet. Physiotherapy was involved, so they're involved in kind of positioning for this patient in order to support with their swallowing being safe. Radiographer was involved, so when I spoke about the video swallow and the video fluoroscopy, the radiographer is involved in the in administrating that. Had the overall kind of oversight of the stroke consultant, and then when moved into the care home around the GP. So they've kind of got, they're the people that we liaise with when we make a change in the swallow management plan, and they kind of have the kind of whole oversight of everything that's going on. Occupational therapy were involved. So for this lady, she also had some cognitive difficulties. So she was seeing occupational therapy for that. And we worked carefully alongside occupational therapy in order to complete things, for example, like a capacity assessment, which I mentioned earlier. So that involved the speech therapy and occupational therapy to complete. and pharmacy as well. So this lady had swallowing issues. Like I said, she was on puree diet at one point. So pharmacy were involved in order to find alternative ways to give her medications, because swallowing whole tablets was unsafe. She was required to have alternative forms, so like tablets crushed or liquid tablets. So yeah, a lot of MDT working. And the outcome for this patient, so like I said, I'm still currently working with her. She still has significant communication difficulties. So expressively, her kind of verbal communication is quite limited. Her understanding has significantly improved since we've been working together, and her overall kind of use of alternative means to communicate. So even though her expressive language is still quite difficult, she's able to participate in kind of activities, some of her hobbies and activities of daily living, through the use of using alternative means of communication. So like I said, using apps, using writing, using typing, using non-verbal communication, like even her use of kind of gesture, pointing to things to kind of indicate to staff what she wants. All of that has significantly improved since I've been working with her, which in turn has kind of improved her quality of life. So her ability to kind of participate in ways maybe not as she did before, but like, for example, reading her child a bedtime story isn't done verbally anymore, but she's able to do that in alternative ways, for example, by using apps and other means of communication. So yes, that's all from me. I hope that was all okay.
Thank you so much. That was brilliant. I've learned a lot myself, so thank you. And that concludes our healthcare careers in focus for this week. And see you all again soon.